I'm not Katya. I'll try to do my best with her presentation. This is a bit of a mixed business technology mechanism of action for something we are doing today. And my strength is obviously that technology, so I might focus on that. What have we done? We have developed neuromodulation wearable platform to treat pediatric disorders. So what is it that we're focused at today is autism. For reasons that are personal to some of the funding members of the company, for reasons that have to do with a lot of us being parents, this came up to us as something that needed to be taken care of. And critically unmet medical need. Turns out that there's about 2 million kids in the US that have autism spectrum disorder. And it's a bigger problem than you may expect. It's growing. And what struck me as a technologist was that 85% of these kids remain unemployed. So they have to be taken care by the system. Roughly a third of them remain non-verbal. The cost to the US economy is estimated to be about almost $500 billion next year. So this is a real problem. It's something we wanted to address. Now, this is where my expertise comes about. Why do we think that the technology we have developed can address this disorder? We think it can because it turns out that in about 80% of these children, the dysfunction can be traced to mitochondrial problems. So the mitochondrial in the neuron and in the supporting tissues of these children are not functioning the way they're supposed to be functioning. So what does that mean? That means things like, for these children, neuronal cell death is much higher than for a normal child. For these children, the connections between the brain areas of the default mode network are not developing normally. So they are not actually, their brains are not growing in a way that's functionally predictive, the way we grew up. And also, we just got a nice lesson on inflammation, chronic inflammation, neural inflammation. Part of that sequela of mitochondrial dysfunction is neural inflammation. The brain cannot actually take care of itself to get rid of the garbage that being alive produces. Now, kind of deviating a little bit, what we do today to treat these children is behavioral therapy. So yes, it's helpful. Yes, you can take this child and basically what you're doing is teaching them how to cope. And it helps. They learn how to cope. If they are in the low end of the spectrum, they can become a little more functional. The higher end of the spectrum is just palliative. You just learn how to cope. Now, it is inaccessible. It takes multiple hours a week of training therapy per child to be able to get them to a point where they're as self-sufficient as you can make them. And it's very expensive. More importantly, to my way of thinking, it doesn't address the problem. It helps the child, but it doesn't address the problem. So I think, that light, some specific bandwidth of light in the near infrared that can penetrate the tissues of the scalp and the skull can address the problem. So why? The light itself addresses mitochondrial dysfunction. So when you take care of that, and of course, there's abundant literature the last 20 years, 25 years that is being explored extensively that demonstrates, not by me, although some of it by me, that in fact you can get mitochondrial function reestablished on neural tissues that are deficient, but using the right wavelength, the right intensity of light. So what would you get with that? The first thing that happens when the mitochondria becomes functional is it increases ATP production. ATP is the molecule that the mitochondria of the cell use for energy. So once you get an increase in ATP production, the cell can start to take care of those basic needs, garbage disposal, managing ROS, those basic things that would allow it to survive and to actually take care of the pathological underlyings of things like autism. By the way, this is being tested with depression, Parkinson's, Alzheimer's. All of these have roots in mitochondrial dysfunction. Once you take care of the problem with ATP production, the cells get enough energy to do their work. Now, what does that mean? It means that the apoptotic pathways that led to cell death, early cell death, little children, because their mitochondria is not functioning, are stopped. Does it stop all of it? No, but it stops a lot of it. And you can imagine that every surviving neuron is going to have some effect. Now, with these functioning cells, what you start to get is some additional connectivity between the neurons. So the default blood network starts to develop in more normal ways. The way we design our device is to encourage those pathways, language development, executive function. And finally, he reduces neuroinflammation. So in a way, you're counteracting a lot of the pathology for the disorder very early in life. We're treating children between 2 and 8 years old. Now, this is just kind of a slide to say that this technology is being designed for the purpose. So near-infrared light to treat neurological disorders is not new. Been doing it for 25 years, but it doesn't work one size fits all. Each disorder requires slightly different ways of treatment. So when we treat Alzheimer's in an adult, you use a high intensity light of a certain wavelength. This one is designed to treat the child with the right intensity of light. Too much light is not great, in the right areas of the brain for the right amount of time. Now, that's what the device looks like. It's web connected. We're collecting data. We're doing a clinical study. We're developing it so that at the end of its life cycle is going to go into a commercial environment. It's going to go directly to the child. So when we finish our pivotal, we're going to design a device that is going to be wearable, easy to use. It's all battery operated. It has no wires. A clinician is going to look at it, prescribe it, and he goes to the child's home with the child. It's going to be designed to be easy to use, user friendly. The mom can use it. But, okay, so we tested our ideas. We tested this idea over 3 different clinical trials, feasibility trials, I should say, small. In total, 70 kids. Our first study was 30. It was an RCT, 15-15. He demonstrated significant effect. Not only was it significant, but he met the criteria the FDA deems clinically meaningfully beneficial. So when you look at the FDA, you have to say, okay, we're going to have to use a metric the FDA is going to approve, otherwise spinning your wheels. We got breakthrough device designation from the FDA, non-significant risk device designation for the clinical study. We did this study and we met their criteria for approval. So as a breakthrough device, they kind of guide us through the process. Following that, we did 2 open label studies to test usability, tested on older children. We reproduced the study. The bottom line is for 70 kids, we were able to get much better than what the FDA wants for a clinically meaningful signal. Now, in addition, because I'm an engineer, objective measures become important. I've been doing this for a long time. The same question comes up every time. How can you work for all these things? It's not magic. So it's not subjective. What can we do about it? What can we do to demonstrate to the world that there's something physiologically changing? I thought use EEG. It's a simple metric. It's a simple way to measure things. There's a lot of data. Move forward. The neural pattern on these children change. And they change in a way that drives them towards neurotypical pattern. And we can do these every time. So the feel good part of these is when you get response from parents, right? You get a mom that says, hey, my child said, I love you for the first time, 4-year-old kid. Or they can take care of their bathroom needs. Or they behave more socially in school. We get this all the time. So what have we done? We have raised $5.5 million to this point. We have done a pilot device. Like I said, we interact with the FDA. We have a couple of patents, more pending. Right now, we are in the middle of, not middle, about a third of the way done with the pivotal trial. And we expect to finish next year. So, like I said, by this time next year, we expect to have FDA clearance in the de novo pathway. Market, where are we going with these? Initially, this is going to be used in ABA centers, just to understand how this works. One of the things we don't want to do is fight those things that are reimbursed, fight clinicians that have an understanding and an expectation. So we are working to show that the technology is synergistic to ABA therapy. So how is this possible? Well, the first few things that we see in these children is their attention changes. They start to pay attention. Their focus changes. They start to spend more time paying attention. They start to respond to the therapist. So you can imagine that if 20 hours a week you're trying to get this child engaged in some kind of behavioral change, if you can get them engaged, the therapy itself works better. Early investigation suggests that this is in fact going to happen. It is true. We have several centers ready to get there with us when we get ready and our approvals are done. This first market is about $1 billion. What we expect after that is to develop a device that can be taken home. The business model is to have clinicians prescribe the device for the parent to take. So we believe that market, that addressable market is about $2 billion. Ultimately, we want to have reimbursement, and we'll work towards that. We feel that we can be profitable much before having reimbursement. That's a long way to go, and we're working towards that. So this is more or less what we're seeing. There are no days here because we really have no idea when we're going to start. We're hoping that's next year, but over a 5-year period, the growth curve is what you expect, right? If you've seen presentations, pitches about these things, it's always like that. Well, we think so. Bottom line is we talk to people like Medtronic, Boston Scientific, and they're saying, looks good. Come back to us when you have FDA approved. All right, we will. We're looking at a 10x return somewhere around A. And of course, the overall applicability of these technologies is much broader than autism. We're talking about ADHD. There's no reason why that wouldn't help for that. We're doing a clinical study that's separate to try to help kids that have epileptic seizures. We're getting great results. So right now, our focus is autism, but the technology is much broader than that. Our regulatory clearance pathway, 2025, 2026 for the first device, the clinic base, 2027 for the home base. Then we're going to introduce some personalization ideas, AI. We're going to try to collect data. With home-based devices, that becomes itself a clinical study that we can use for reimbursement. And there will be other indications that we're playing with that come out around the same time. These are us. You can look at us. We're on the web, JelikaLite. Advisors. So what are we trying to do? We're trying to raise $7 million to get those things we just said we wanted to get done. So platform development, manufacturing, salaries, and other things, most of the money goes into clinical studies. Where are we going with this funding? First, finishing the pivotal study. We expect to have done next year. Now, we need to test and validate a commercial device. For those of you that are familiar, clinical devices don't have to meet certain regulatory hurdles. Part of this is being able to sell in Europe. I've done this before. We'll go through MDR. We have to get safety testing. The money will be used for that. FDA de novo submission, manufacturing, and then get devices ready for our first introduction to the market in the clinics with 25 clinics, ABA clinics, that have been already selected and they're on board to do this with us. Large and growing market, FDA breakthrough device, experienced committed team. That's why I think this makes sense. And by the way, going back to the earlier talk, inflammation, this technology addresses that. If you look at Parkinson's, Alzheimer's, depression, chronic inflammation. Previous speaker is absolutely right. And when somebody asks, what do you do about it? Light therapy, look for it. There are studies going on today. They've been demonstrated to address things like anti-inflammatory cytokines, TNF, TGF, the interleukins, all of those things going the right direction. So I'll take questions.
All right, thank you very much, Luis. I have a quick question. The photobiomodulation, what's the wavelength or wavelength range we're talking about?
It's broad. So we are using around 850 nanometers. It's an LED, so it's not narrow, but the technology, the technique works anywhere from red to low infrared.
Okay, so there's a wide range of wave on the wavelength. What about the intensity?
It depends on what you're trying to treat. For us, we treat with what's relatively low intensity. So
How much optical power?
Somewhere around 80 milliwatts per square centimeter in 16 different locations.
Okay, so about 80 milliwatts. And what percentage of that output is going through the skull? What gets to the brain?
On a child, about 12%.
About 12%, which is somewhat comparable to what you might see with non-invasive electrical stimulation.
It's very different because this is not a field effect.
Ooh, okay, so it's very targeted. Okay, why not laser stimulation?
I have used lasers forever. There are two basic reasons. They're a little more expensive.
Right.
They're not really necessary. And eye safety. An LED, because it's a broadband device, is a lot easier on your eye. The biggest problem with lasers is that they are not necessarily eye safe.
Okay.
And if you're going to put this into a child home.
But you said it's important to be very precisely targeted.
The LEDs can be just as targeted as a laser. Nowadays, today's LEDs can be just as, let me take that back.
What's the
They're not
difference?
coherent, they cannot be pinpointed, but they're sufficiently targetable to do what we need.
All right, very interesting. I think we have some questions.
Hi. You mentioned the importance of getting the intensity right and the locations right. And I'm curious, if you gave a blanket effect, what would go wrong? And did you do experiments to find out what are the right locations?
Your first question, nothing will go wrong per se, right? It's you heat the tissue. So you're actually heating the skin, because if 12% of the light is getting to the brain, 88% is stopping somewhere. So putting light in places you don't need it is not only inefficient, it's thermally unproductive.
And how does this compare with one of those laser hats repair with?
Oh, it's about 15 times brighter, more intense. Each 15 times, each therapy spot in the head, it's 15 times brighter, more intense than those things that they work, by the way, I'll be bold by now if I didn't tell you.
Apologies in advance. I come from pharma, so seeing kind of the design of the study, I have a couple of questions. So was it the comparator like the standard clinical practice, which is one-to-one sessions with a behavioral therapist? Because if not, then you're adding cost to the healthcare system if you go on top of that. The second, what was the duration of the result that you showed? Because it would be interesting. And then if you would have a longer study, right? Because usually the proof of concept would be a short one. Do you expect a ceiling effect on your outcome?
Great question. So the first question is how we're going to address the marketability, the pharmacoeconomics of using these with ABA. That's a great question. What we're expecting to see is a reduction on therapeutic time from 20 hours a week to less than 10. So even though the devices cost a certain amount of money and they're going to be believed to be treating per treatment sequence, by cutting 10 hours a week of therapy time, it's about a 10x ratio of cost to benefit. If in fact it works the way we want it to work. Now, to your other question about therapeutic effect, there is not a ceiling per se, but there is once you stop treating in a certain population, some of these kids, the therapeutic benefit starts to decrease. He never goes to zero, so you're never back to baseline, but it does diminish over time with about half of the kids. So that's why we want to use these home devices, where you can just continue to treat and monitor the treatments via cloud connectivity.
Thank you very much for the presentation. I just had a question about, so you mentioned, I know some studies have connected the glymphatic system and glymphatic issues with autism, and then other studies have found that you can use infrared light to modulate, increase the efficiency of the glymphatic system. Have you guys looked into that at all in your studies, or have you had a chance to look at that so far?
Not for this particular study, I have not, but I have played with these before and for treating breast cancer and some of the lymphatic drainage that you can increase. So the short answer is that there are studies that show that near-infrared light can increase the permeability of the blood-brain barrier. So when I mentioned there are garbage disposing mechanisms, yes, this in fact will help with that. We have not studied it with these populations.
All right, that's all the time we have. Thank you very much.